So it's my pleasure to introduce one of our newer colleagues, Dr. Hao-Wen Sim, a medical oncologist currently working at the Kinghorn Cancer Centre at St Vincent's and the Chris O'Brien Lifehouse located at Prince Alfred. He's a research fellow for Cogno, which I've mentioned earlier, and he's also completing his final year of a Master of Biostatistics at the University of Sydney. His main subspecialty interest is in the management of brain cancer, and he's just completed an international fellowship over a 3-year period in Toronto, Canada at the Pencer Brain Cancer Centre. So please make Dr. Sim very welcome.
Thanks very much. It's a pleasure to be here. So as Liz mentioned, I'm a medical oncologist, and my area of expertise is in the systemic therapy of these brain cancers. And by systemic therapy, we're talking about drug-based whole-body treatments. And conventionally, this is in the form of chemotherapy, so cytotoxic chemotherapy drugs that work by and large by attacking cells that are dividing rapidly, and preferentially these are cancer cells. But I guess more in the research setting and going forward is looking at more personalized, targeted approaches, potentially looking at some more novel immune-based approaches that will cover some of the foundations of this going forward today. I think just to start though, I just wanted to recap, I guess we've had a very good introduction to surgery and radiation, where the 3 different modalities of surgery, radiotherapy, and chemotherapy come together. At a basic level, we look at different grades of glioma, and they can direct to an extent which combinations of surgery, radiation, systemic therapy might be useful. The grade refers to the degree of differentiation or how abnormal the cancer looks under the microscope, with grade 1 and 2 low-grade gliomas being, I guess, more indolent and more similar to normal healthy cells. And grade 4 gliomas, you can see that the cells look much more bizarre. These are much more active, aggressive cancers. They can grow much more quickly. And grade 4 gliomas are what we synonymize with glioblastoma. And so that's a very useful way of breaking down gliomas in general. I guess we increasingly recognize some of the different molecular pathways that differentiate these cancers. For example, grade 1 gliomas are quite a different subgroup of tumors. They often affect very young people. This is more pediatric cancer. And the underlying molecular processes that drive grade 1 gliomas are quite different. In sort of younger adults, we tend to see some of the more low-grade, grade 2 and 3 gliomas, and characteristically these have this IDH mutation. These tend to be more slow-growing, and they can be therefore controlled for years, potentially decades. But there's always a risk that these cancers can change over time, and you can see that they can transform into this more aggressive secondary glioblastoma at the bottom. And then more in older adults, we have this one on the far right, the primary glioblastoma, that starts off immediately as a very aggressive type of cancer. And the reason to point this out is that depending on what sort of glioma we're dealing with, some of the specific molecular features that drive these cancers are a little bit different. And so in the past, we've just given standard chemotherapy, which targets cancers in general. But as we move towards a more targeted approach, and we're trying to target specific mechanisms, increasingly we're trying to understand which of these pathways are at play for each specific glioma so that we can deliver a more targeted approach. Just in general at the moment, with the more low-grade gliomas, these tend to be slower growing, potentially more localized. You can see that surgery and or radiotherapy, these being local treatments, tend to have the predominant role for the low-grade gliomas. As we move towards grade 3 and then grade 4, we tend to introduce the combination of all 3. And certainly for grade 4, we sort of give it everything. These are the more aggressive cancers. We give the surgery, combine radiation and chemotherapy together to try and maximize the benefit of the radiation, and then give more chemotherapy afterwards. So we sort of pull out all the stocks to try and control this as best we can. And again, this has been covered before, but just to emphasize again, these are primary tumors arising from the brain. They have a very infiltrative, diffuse growth pattern. This is a cross-section through the brain. The green bits are the active cancer cells. I don't know if you can see this dotted red line, which represents the main tumour mass. And this is what, at surgery, you'll sort of take out a clean bulk of cancer. But because it's such an infiltrative process, there's usually cells that may extend beyond that into the surrounding cavity of the surgery. And then you might then apply radiotherapy. You can sculpt that very effectively around and capture the vast majority of that. But being such an infiltrative cancer, it's very easy for there to be at least a few tongues of cancer, even a few cells left outside that field, even perhaps on the other side of the brain. These cancers grow deep into the nerve networks. And that's why it's very hard to cure, I guess, just with local therapy, and hence the role for having a whole body drug-based treatment to try and treat what cancer might be left behind. In terms of what we use, our mainstay is this drug called Temozolomide. It has been a standard since at least 2005, Roger Stoop and that paper that Sue mentioned before. Temozolomide is an oral capsule that you can swallow. It's a very small molecule, and the reason you can take it orally, being a small molecule, it can be absorbed through the gut. And also being a small molecule, it can get through these tight junctions in the brain and actually get into these tumours in reasonable concentrations. The temozolomide, once it gets into the cell, gets converted into the active compound, which then directly interferes with the DNA cell cycle machinery, and then hopefully will cause cancer cell death. And the way the chemotherapy works, by and large, those cancer cells are more aggressive. They are going through the cell cycle more frequently, and therefore they are preferentially affected by chemotherapy. And the other principle being, of course, that normal healthy cells can regenerate and repair more effectively. Cancer cells have defects in DNA repair, so we give some chemotherapy for a high dose. We may damage both the cancer and the healthy cells, but we do hope of a period of recovery. The normal body will recover effectively, whereas the cancer cells will not repair to the same degree. And we will give cycle after cycle, causing preferential damage against the cancer. Down the bottom is the schema showing the classic way we give temozolomide with radiation, followed by further temozolomide in glioblastoma. So typically between 3 and 6 weeks of radiotherapy with daily temozolomide, a 4-week break, and then we move into the second phase where we give a higher dose of temozolomide for 5 days, followed by a 23-day break. The rationale for 2 different phases. The first phase, the temozolomide is just given at very low dose. This is just meant to sensitize the cancer to the radiation. It's meant to make the local radiotherapy more effective. And the second half is more looking at that systemic effect for the chemotherapy. We're giving big doses, trying to cause damage to everything, hopefully more of the cancer, and having that period of recovery for the normal healthy cells to recover during that time. So this is the temozolomide capsules. So we formulate a dose based on the weight and height, and we make it up in the form of capsules. And we give support medications to go with that to try and make it tolerable. Typically, we'll give at least some form of anti-nausea medication that you would take about 30 minutes or an hour before the chemotherapy. And we often give a prophylactic antibiotic called Bactrim or Respirem Fort to try to minimize the chance of an uncommon chest infection that can happen when people have been immunocompromised with the combination of steroids and recent radiation and chemotherapy. Side effect-wise, it is a chemotherapy. There can be side effects from chemotherapy, but I would say on the spectrum of different types of chemotherapy for cancer in general, from very strong that you might give for leukemias or for adjuvant breast cancer, these are very strong regimens. In average, temozolomide tends to be on the other end of the spectrum, tends to be, in most people, relatively well tolerated. The most common side effects would be fatigue. There can be some nausea, but we'll usually control that in most people quite well with the anti-nausea medications. We do look out for the bowel habit. Constipation can be a problem because of the anti-nausea medications, so it's just important to keep that under control. And probably the main thing is the effect of chemotherapy, these older style cytotoxic chemotherapies on the bone marrow and the main blood cells. So we have, in particular, the platelets and the white cells that we are worried about. Platelets are important to stop bleeding, and so if they're very low, we worry about tumor bleeding or bleeding in the body in general. So in the bottom left here is a picture of these very fine pinpoint hemorrhages or bruises that can happen if the platelet count is very low. And this is one of the reasons that during that continuous phase of radiotherapy and temozolomide, we would check the blood tests quite frequently, at least once every 2 weeks, sometimes weekly. And the reason is that on that graph on the far right, the platelet count can be very good for much at the beginning of that treatment. It can drop off quite precipitously if we're not being careful and checking that and monitoring that. The other thing being the white cells, if these are low, there's risk of infection, and so we'd advise a fever, classically over 38 degrees, so just feeling really sick with infective symptoms in general. We'll be very cautious and try and treat that quite strongly with antibiotic therapy. And that has been the mainstay. I would say that overall, despite those side effects, we think this is one of the more manageable chemotherapies. And even people who have been through a lot with the surgery and radiotherapy, most people tend to tolerate this reasonably well. Just to introduce some of the other chemotherapies that you may have come across or may come across, there is another regimen called PCV, and there are 3 drugs that make up this regimen. The P stands for procarbazine at the bottom. The C stands for CCNU or lomustine at the top, and the vincristine is the V. This combination of 3 drugs is an effective regimen. We often have given it for the grade 2 or 3 gliomas, and is at least, I think, as effective as temozolomide, but perhaps more difficult to give. And so side by side, some people prefer giving temozolomide rather than PCV in that setting, but that's still an unanswered question. But this is a regimen you may see in the lower grade gliomas, and certainly even for glioblastoma, we may use elements of this. Lomustine or procarbazine can be used on their own in glioblastoma. The PCV regimen is quite complex. It's a 6-week regimen. You give a dose of lomustine at the start, you give vincristine on week 2 and week 5, you give procarbazine across weeks 2 and 3. You can see it's quite a complex regimen, and being 6 weekly, it takes some time actually for the body to recover, hence this long cycle. The range of other drugs that you might try in the setting where someone is still well enough for chemotherapy, but you've tried the standard drugs. We have in Australia tried intravenous carboplatin, oral etoposide, and you have the occasional person who will benefit from that. It's just very hard to pick. The overall response rates are quite small. And then there's another drug working slightly differently called bevacizumab or Avastin, that we may try and introduce in the second-line setting in certain people. This is not a conventional chemotherapy. This is what we call an anti-blood vessel drug. It attacks cancers by trying to deprive them of their essential blood supply. So cancers need nutrients to grow. If we can stop the blood vessels from getting to the cancer, they don't have enough nutrients to grow. This basically binds what we call VEGF, which is a growth factor for blood vessel growth. And we can stop VEGF from being able to grow new vessels into the tumor. We may be able to stunt its growth. And I guess the rationale here, this works very differently from standard chemotherapy, so it can be quite complementary in that regards. It also has the effect of potentially normalizing some of the blood vessels and making it less leaky. And perhaps in people who have a lot of swelling around the tumors, this might be an appealing strategy. At this point in time, it's not a subsidized treatment. There's a way to get it through a sort of a co-sharing payment program. And part of the reason it's not subsidized at this point is that whilst we know it has potentially good anti-swelling effects, the direct anti-cancer effects in terms of long-term survival difference are less clear. And so the cost-benefit ratio is not that certain at this point, but something that we may still entertain as something useful in certain people. And I would say that group of drugs has been really all we have had for a long time for glioblastoma. Moving forward, and certainly in the research setting, we're looking at one strategy of more personalized targeted therapies. I showed earlier on the different molecular pathways, and looking to see if we can block some of those key pathways in a more targeted fashion. Maybe we'll have different results to the more broad-acting chemotherapies. Now, with the updated sort of classification of gliomas as standard of care, we do get some information. We know they have IDH mutations. We know things like MGMT status, 1p19q co-deletion. And going forwards, we may be looking for things like the EGFR V3 amplification, which is present In a reasonable number of glioblastomas, about 40 to 50% may have this amplification. And this may be a pathway worth targeting. There have been a few trials very recently looking at this and awaiting some more formal results from that, where you can target that through various means. There are some vaccines that have been using this, trying to target this pathway. You can use what we call antibody-drug conjugates, where you have a molecule that targets the amplification attached to a cytotoxic molecule that will try and attack the cancer. IDH mutations have been very common in the lower grade gliomas as an attractive target. There have been a few direct IDH inhibitors that have been tried in early phase trials, and we should have at least some results at the upcoming ASCO conference on the IDH inhibitors. IDH mutations may also confer sort of DNA repair defects, and there's some interest in looking at PARP inhibitors for these tumours. We had a recent trial called Virtue looking at a PARP inhibitor called veliparib, trying to exploit this kind of mechanism. There's something called NTRK fusion, which is uncommon, but in other cancers where we have targeted and found this particular fusion product, a specific drug targeting this pathway has seemed to be effective in quite a lot of people. And then there are more, more novel, less explored pathways that we're looking at, the anagen pathway, ephrin pathway, NF-kappa B pathways. There are some early phase trials around where if we really do not have other options, we may try and use targeted drugs to blockade these pathways to see if they may be effective. But across the board, this is still an area that we are innovating in. And you're probably aware of the other paradigm of immune-based therapies. And the approach here is, instead of trying to attack the cancer directly, let's try and get the immune system to see the cancer and get the immune system to attack the cancer. And what is potentially appealing about this is that, cancers generally, even if they respond to chemotherapy, become resistant after a period of time because they're dynamic processes and they will find ways to evade the chemotherapy. The immune system is also a dynamic process, and potentially if you can get the immune system to recognize the cancer, hopefully the immune system can keep up and dynamically keep up with these cancers. And potentially immune therapy, certainly in other cancer types, have been able to show more durable responses. And the classical one being melanoma, where there has been marked success with this approach. But importantly, different cancers are different, and there are other challenges that make immune therapy in brain cancer more difficult. And some of them being that the brain tumor environment by its nature is a very immune suppressive environment. It's very hard to create an immune response in that environment. There may be issues with access of drugs into the brain to where these immune agents have to act. And I guess the immune system in the brain may be slightly different anyway to outside the body. There are different approaches to trying to get the immune system to work. The more classical one has been in these two green boxes. There are these two key interaction parts of the immune system that we can try and upregulate to make the immune system more active. At the bottom box is where the immune system is trying to recognize that there is a cancer there, that something abnormal is there, and once it recognizes it, will go off and replicate and form these killer cells that will go back in the top left, top right box. Will go back to the tumor and try and kill the tumor. These are two key interactions. And for example, we have had a number of trials looking at the drug called nivolumab, Opdivo, which interacts with this molecule called PD-1, PD-L1, which is trying to make cancers more visible to these attacking cancer cells, trying to take away the cloak that PD-1 provides the cancer cells. And this is still an area that we're looking at. It seems that single-agent checkpoint inhibitor therapy like this may not be strong enough in brain cancer, so we're looking at more novel combinations, either with targeted or chemo or a combination immune therapies. And I guess, we're quite innovative. We're looking at other ways to try and get the immune system to work. On the top is what we call vaccine-based therapies. So for example, with the EGFR-V3 pathway, we may purify that specific abnormal EGFR-V3 peptide and try to make it into the vaccine, similar to having vaccines against infections, the idea being that the immune system will be able to be stimulated to recognize this specific peptide that's localized to the tumor. This doesn't always work because it may be hard to prime the immune system in that immune suppressive environment. So another approach has been in the bottom, what we call adoptive immune therapy, where we actually take out from the body through like doing a blood test, you take out some of the important elements of the immune system, and that may be T cells or dendritic cells. And then outside the body, we prime it outside the body, especially in the lab, and then we reinfuse the activated cells back into the body where they're already activated. You can go back and specifically, hopefully, attack the cancer. And these can form a variety of therapies, dendritic cell therapies. There are also ways of directly modifying T cells, so you may have heard of things like CAR T cell or BiTE cell therapy. So this is an area of innovation, another way of trying to turn on that immune system. And I guess finally, another approach has been to use modified viruses. And one example of this is the modified poliovirus. The group at Duke University injected modified poliovirus directly into recurrent glioblastoma tumors. They're modified so the polio won't cause polio, but will try to specifically infect the cancer cells. And through this process, can directly cause cancer cell death. But also just by the virtue of infecting the cancer cell, it makes the cancer cell abnormal and potentially more visible to the immune system. Also, if there is cancer cell death, it will spill its contents into the surrounding environment, again providing potentially a signal to help activate the immune response. This is still in very early phases. They did publish that phase 1 data on the right. And this is a graph showing survival after recurrence of glioblastoma. And you can see that on average, survival is very poor. But what they did see was that, at least in this very selected group of patients, there was a small group of about 20% who seemed to have long-term benefit potentially from the poliovirus vaccine, which is something we haven't seen before in this very difficult to treat setting. So at least that's very encouraging. That has led to a lot of other groups looking at other forms of modified viruses. And you may have heard of other forms of adeno or herpes viruses or CMV viruses have been modified to try and engender the same kind of approach. And I guess the final thing we've been looking at in terms of systemic therapy have been other ways of trying to improve penetration of drugs into this space. We have been very limited in terms of chemotherapeutic options to a large degree because a lot of the other anti-cancer drugs that might work for other cancers do not get into the brain very effectively. And so one strategy has been to use what we call nanoparticles. This is still very much in the research setting or early phase trials, where you try and package these molecules into inside nanoparticles that may be able to use specialized transporters that can get across the blood-brain barrier more effectively. And of course, the concept would be, if you can get more drug into the tumor, wouldn't that be more effective? Potentially, there may be other approaches. There's an approach of trying to cause temporary blood-brain barrier disruption, where you might, for example, inject microbubbles and then in a targeted way give ultrasound to cause a temporary breach of the blood-brain barrier. And again, the principle would be you give chemotherapy and hopefully in those specific areas of breach near the tumor, you'll get more tumor uptake of these chemotherapeutic options. And I guess theoretically, if we're able to do this in an efficient, effective way, we may have therefore more drugs to look at that might be effective against brain cancer. And so, our core drugs are still very limited, but we do try and push forward in this space, and clinical trials have been our mainstay. We do have clinical trials around, and I guess these are the key websites that we would, if you're looking for trials, this is where the main registries would be. The clinicaltrials.gov is the international register for trials, and you can search for trials based on different cancer types. The ANZ CTR is the Australia-New Zealand Clinical Trials Registry. And then on the far right is what we call ClinTrial Refer. Perhaps this is a little bit more updated, that a lot of us will be using nationally in Australia. And then the Cognitive website has a few listings of trials as well. And so I guess this is an area of innovation, but still not quite prime time for a lot of these more innovative therapies. So I guess questions, but maybe we'll leave that a little bit later on.